Vascular access is an important part of the things that we do when we look after patients with CRRT. As I'm sure all of you practice in this field know, there is a whole menu of vascular access devices that are available from which one can choose. And you might ask yourself, well, does it actually matter? Well, it probably does. And we know that because of a variety of studies that I'm going to go through in the next 20 minutes or so, but also because of the daily practice that highlights the fact that, in fact, vascular access, the double lumen catheter, is the weak point of continuous renal replacement therapy. It has very important relationships with blood flow through the circuit, with the way the blood pump is able to deliver the prescribed blood flow, and the risk of filter failure that emanates from that. I wanted to show you this diagram because maybe some of you don't quite think about why the blood goes from the vein into the circuit and how a peristaltic pump works. Peristaltic pump compresses the tubing of the circuit, and as it rotates, it creates a suction effect by squashing the tubing and then allowing it to expand. As the tubing expands, it creates a negative pressure, and it makes the blood flow from the vein into the tubing. The tubing gets filled up again, and then the next rotation of the cam moves it forward. One of the things that some of you might believe is that when the pump is set at a particular value, that is the blood that will flow through the circuit. But in fact, that is only measuring the rotations of the cam. And then it calculates the likely blood flow that will come through the circuit. But if you are able to monitor the blood flow with a Doppler flow probe around the tubing of the circuit, you will see that flow is often not quite as much and as predictable as you might think. You will find, for example, that as you would expect, the flow is not steady and continuous, but it has a cycle of systolic pressure and diastolic pressure. And then as the tubing refills, the next cycle gives a kick of flow, and then it goes down again, and it starts again with the cams moving along. Also, the flow is not steady, and that is because all sorts of things can happen in the position of the catheter, the interaction between the patient and the catheter, that will generate difficulties for the pump to deliver the flow that it wants to deliver. And we know that these episodes where the flow is actually reduced vary depending on the site where you've inserted the catheter. And the subclavian site is particularly prone to having problems with flow reduction. The jugular a little bit more, and the femoral appears to be less likely to cause flow reductions. Nursing interventions also create problems, and not because they shouldn't take place, but because they move the patient. And the patient is rotated to one side or rotated to the other side. And if there's a catheter in the femoral position and the legs are flexed, that can create resistance to outflow. If the catheter is in the subclavian position, changes in position, change the way in which the catheter relates to the lumen of the superior vena cava, and you can see how 1 in 5 interventions is actually associated with flow changes. And these flow changes vary depending on where the catheter is located. And again, the subclavian catheter appears to be more problematic than in other positions. And of course, in our experience, it is associated with shorter fetal life. And that's why really over the last more than 7 or 8 years, we've stopped using the femoral access. There are issues about long-term dialysis, of course, as well, but it's really kind of disappeared. Do we have randomized controlled trials to tell us anything else about access site, the position where we should insert whatever catheter we have chosen to buy and apply to the patient's care? Well, this is a randomized controlled trial by the French group looking at the risk of infection of the catheter depending on the position where the catheter is inserted. This is a large trial. It's multi-center, well-conducted, randomized, published in JAMA. Patients were comparable at baseline in terms of age, sex, distribution of body size, Apache score, and a variety of characteristics. And you can see that at that time in France, anyway, ultrasound-guided insertion was really uncommon. And I am assuming that for all of you now, that is the obligatory standard of care as it is in my unit. And you can see that the time required for insertion was not too long, and the first attempts on the right side were similar in distribution. So these investigators were able to prospectively look at catheters and look at the days of insertion and problems with function, and able to measure catheter colonization at the time of removal by sending the catheter to the microbiology department. And then when comparing the femoral and jugular site, you can see that there is no significant difference in the timing or incidence of catheter colonization, telling us that at least from that point of view, these two sites are equivalent for catheter insertion. However, this large comparative assessment hides a little secret within it. And the secret is that the statement that femoral and jugular are equivalent in terms of colonization needs to be seen within the size of the patient. So if you're inserting a catheter in patients that are large and have got a high BMI, then the femoral site is associated with a greater risk of colonization. And it makes a lot of sense. And I'm sure those of you who've inserted femoral catheter would know that the area is often covered by adipose tissue. It gets very sweaty, and it wouldn't surprise you to find that this is indeed a risk for a colonization. The opposite is true if you're thin. So if you have a thin patient, the risk is greater if you're in the jugular position. And again, the femoral position for a thin patient is nice and clear. There's no skin fold. It's an easy insertion. It's easy to take care of. Often the area around the neck has got, particularly for males, got a beard. The adherence of the plastic cover or whatever area of protection of the catheter you might be dealing with is suboptimal. So this makes sense. So if you have a large patient, go to the neck. You have a thin patient, go to the groin, preferentially. Of course, there might be all sorts of other issues in individual patients that need to be taken care of. And this is the visual representation in Kaplan-Meier curves format of the differential risk of catheter colonization according to your body mass index. The same group of investigators looked at catheter dysfunction. Now, this is a different outcome. So they've looked in the study at colonization, and this is catheter dysfunction. And again, comparing different sites. So they wanted to look at how often catheters were removed, because at a clinical level, their function was considered suboptimal. They wanted to look at their ability to achieve urea reduction ratios if you were receiving intermittent dialysis, and how much downtime there was. And they wanted again to compare the femoral catheter to the jugular position. And again, as you already see there were no differences in catheter dysfunction overall between the two groups. However, again, hidden beneath they're all the same. There is a difference as to whether you have the jugular catheter in the right versus the left jugular position. And again, it shouldn't come to you as a surprise that the right jugular has less access dysfunction than the left, because clearly the position and the shape of the catheter needs to take to be in the correct position in the superior vena cava is different. So if you can, go for the right jugular if you want to have a limited catheter dysfunction. And of course, again, very often this is dictated by other specific patient characteristics. Now, in the renal trial and in this study by Parienti, a lot of patients had a femoral catheter inserted, And one of the things that come up all the time when discussing things about the site selection is whether the insertion in the femoral vein is risky from the point of view of deep venous thrombosis. And that seems very logical. It's a very large catheter. It's inserted in a major vein. It's getting the blood back from the leg. The patient is immobile. So this is a very reasonable question to ask. There are no randomized controlled trials that have actually tried to address this issue. And the only way we could try and address it is to look at the incidence of deep venous thrombosis in the leg in a large cohort of patients that had a femoral catheter inserted. And this is what we got. We had 483 patients, 380 were in the femoral vein, and 370 did not have any thromboembolic events. 10 patients had thromboembolic events as a discharge code at hospital discharge, and 5 of these events actually occurred before the catheter was inserted. So it's very difficult to blame the catheter for that. And 5 had occurred in the patients after catheterization. So in order to kind of get a sense of how bad that is, so we got 5 events out of 300 or so catheters in the femoral vein position. It's very low overall incidence of coded thromboembolic complications. We decided that we wanted to have a group of patients to compare them to. So we got patients that were ventilated for more than 2 days at the same time. So that represented a reasonable control group to us. There were some differences in the patient characteristics, but not too many. And this was a group that would be potentially similar to these in terms of risk. And when you look at the incidence of deep venous thrombosis in the ICU patients, this incidence was actually 4.4%. So the incidence of deep venous thrombosis in the patient that did not have a femoral catheter, were mechanically ventilated for 2 days in the ICU, who were very similar to those that had a femoral catheter, was actually higher. And that makes it really unlikely that having a femoral catheter position is a major risk for thromboembolic complications in the leg. It's not perfect, but that gives you some idea that the risk is low. Then we asked the question, how long can these femoral catheters stay there? Should we remove them? Is it a week enough? Is there a risk of colonization if you let them sit for a long time? What is the risk if you extend the care of these catheters for a long period of time? And so we looked at the catheter-related colonization in patients where there was a femoral and non-femoral position that was extended use. So this is, again, a large cohort of patients with 458, about 647 had a double lumen venous catheter included in the final analysis, 405 in a single site, 53 with multi-site, and those that were in a single site, 334 with 419 femoral catheters, where we preferentially insert that. I should say, first of all, that we have a liver transplant unit with a referral center for the state for liver patients, and many of our patients with significant acute kidney injury requiring renal replacement therapy have platelet counts of about 20,000, are coagulopathic, and there is one thing you can do in the femoral position, that's push on the artery should you injure it, a thing that you cannot easily do for the carotid. And so you look at the distribution of patients here, and it shouldn't come to you as a surprise that patients that had a femoral catheter were not as big as the patients that had a catheter inserted in the jugular. And this is a reflection of the practice that is moving towards giving femoral lines in thin patients, if at all possible, and avoiding them in larger patients, if at all possible. And you can look at the profile of the double lumen catheter and infections in these patients overall, and the use of antimicrobials and the laboratory results and the comparability of these patients. And you can see that there really are no significant, so the infections are uncommon, there are no significant differences between the femoral and the jugular position, and the incidence of bloodstream infections is really quite low. And again, even if you do guide wire exchanges, you compare that to venipuncture, if you look at a switch from a femoral to the jugular, from a jugular to the femoral, again, you've got small differences, but a very low rate, as you can see there, of line-related infection. And I'll just go to the next one, which is the delivery of dose. So we talked about the site, we talked about the choice of patients, we talked about the choice of site in relation to body weight, we talked about line colonization, we talked about extended use, we talked about guide wire exchange in patients where that's desirable, and this is looking at data from the renal trial. This is, you might know, this was a trial that randomized patients to do different levels of intensity of renal replacement therapy, and as part of this trial in Australia and New Zealand, we have data on almost 1,500 catheters, and you can see again the femoral catheter remains the preferential site of infection. And again, there is a difference in weight consistent with what we heard before, and interestingly, clinicians put femoral catheter in preference in patients that got more severe acidemia. I'm imagining that the patients are sicker and people want to move on, and there is already a right jugular line, and so there is part of resuscitation that might impede insertion in the femoral position. These patients' hemoglobins are a little bit high, which suggests we're intervening earlier. And when you look at the delivery of the CRRT dose in the first complete 24 hours, the femoral catheter actually outperforms non-femoral position. But I should say that some of the non-femoral positions, including some subclavian positions, which, as I said before, are really quite undesirable. And actually, you can see the distribution there. The right femoral vein is preferred. It's easier. The vein goes straight into the inferior vena cava. The left is a little bit curved, which makes it less favorable. And when you looked at on the multivariable analysis, you can see that the biggest decider of whether you will insert a line in the femoral position is, again, the patient's body weight. Now, there is another aspect of inserting a catheter, which is the length of the catheter in relation to the site where you've inserted the catheter. As I say to my fellows all the time, you cannot insert a short catheter in the femoral vein. It's a stupid thing to do. And the reason that it's a stupid thing to do is that at rest, the flow in the external, because you will only get as far as the external iliac vein. At rest, estimated Doppler flow in the external iliac vein is about 120, 130 mils a minute. And so if you put a catheter in the external iliac and then you get to the pump and you dial up a blood flow of 200 mils a minute, you're going to have trouble delivering it. And what's going to happen is you're going to have catheter dysfunction, you have low flow periods, and the access is going to cause problems in terms of filter life. So you have to put the longest possible catheter you've got in the femoral position. And if the patient is large, then you barely get there. Now, unfortunately, manufacturers do not make long catheters that are 30 centimeters in length for big people. So you still get into trouble, even with 24 centimeters, which is unfortunate. But you can see there that, as you would expect, longer catheters are indeed, 24 centimeters, are indeed more likely to be inserted in the femoral position, which makes a lot of sense. And, of course, shorter catheters are more likely to be inserted in the jugular position, which makes a lot of sense. You can see the distribution of types of catheters, sort of manufacturers is similar, and the most common size at that time was a 13.5 French catheter. So does the size matter? It does. And you can see there when you're looking at the delivery of dose in the renal trial, the bigger the gauge, as well as the femoral position, the more likely you are to deliver the dose that you've randomized the patient to in this particular case. Some of you might ask the question, yeah, okay, so you're going to put a long femoral vein catheter, it's just going to try and get into the inferior vena cava if you can, so that you have lots of flow around it, so that the catheter can give you the flow that you want, and then maybe you're able to deliver the dose better than you got a jugular catheter, but maybe it's just because we don't put the jugular catheter far enough. And that's what many Australians think. And this is an Australian randomized controlled trial where they took patients that had hemofiltration, and they randomized them to have a catheter inserted all the way under guidance into the right atrium or in the superior vena cava. This is a randomized controlled trial of 100 patients randomized to shorter dialysis catheter versus longer dialysis catheter. And the patients, as you can see, were similar in characteristics. And then looking at the position of the longer catheter, about 80% of them were in the right atrium compared to 9% of the shorter length catheters. And when you looked at the primary outcome, which was the lifespan of the circuit, there was a significant difference of about 6 hours between those that were in the right atrium versus those were inserted with the intention of getting to the right atrium versus the superior vena cava catheters. And again, the dose of dialysis and the number of dialysis needed during ICU stay and the number that clotted are all different in favor of inserting a longer jugular catheter that goes all the way to the right atrium. And this is a representation of this difference. We've also looked at different catheters in the literature to see if it's not just the length, the size, the position, how far down you put it, but whether particular characteristics as delivered by the manufacturers make a difference. We couldn't find a difference between the Dolphin and the Niagara catheter. We then compared the Medcomp and Niagara catheter because they got a different design. Again, there was no difference in filter life. So let me summarize my presentation by saying that vascular access is important. I know you all know that, but you may not know how important it is. And it's really important if you want to achieve good CRT performance. Duration of CRT is typically short. So tunneling catheter is a problem. So in some patients you might want to do it if you expect that it's going to go on for a long time, but very often we feel that that's not necessary or desirable. The jugular site appears to be best in people that are obese or large. The femoral site appears best in thin people. But of course, there are all sorts of other considerations when you make that decision. From a microbiological point of view, the femoral site is safe, provided you're not using it in a very large person. The DVT risk is relatively small and not particularly higher than in other patients that do not have a femoral catheter. Longer and larger catheters are better, particularly in the femoral position. Insertion from the right jugular is better than the left, and if you put it on the right, it would be important to go all the way into the right atrium. Thank you very much for your attention.